Hello, and thank you for the opportunity to present our work entitled Aortic Annular Enlargement, Short and Long-Term Outcomes in the United States, on behalf of myself and my co-authors. Patient prosthesis mismatch is associated with significant long-term morbidity and mortality after aortic valve replacement, and has garnered significant interest with the rise in transcatheter aortic valve replacement and valve-in-valve TAVR. However, indications and outcomes of annular enlargement in order to allow for a larger prosthesis remain poorly defined. The purpose of this study was to describe the safety and current practice patterns around the use of annular enlargement across the national STS database. We hypothesized that increasing rates of annular enlargement may lead to improved outcomes for patients at risk for severe patient prosthesis mismatch. We began by querying the STS National Adult Cardiac Surgery Database and identified over 600,000 patients undergoing aortic valve replacement with or without concomitant coronary artery bypass grafting between 2008 and 2016. After excluding patients who underwent emergent operations, operations for endocarditis, patients on mechanical support, or those undergoing other concomitant procedures, we had just under 400,000 patients undergoing aortic valve replacement. These patients were then matched with Medicare-linked data to obtain long-term follow-up and survival data. Our final population was 189,268 Medicare-linked aortic valve replacement patients with or without concomitant CABG. Patient prosthesis mismatch was defined by calculated effective orifice area index based on patient body surface area and manufacturer effective orifice area, with an EOAI of less than 0.65 defining severe patient prosthesis mismatch. Patients were stratified by annular enlargement for univariate, multivariate, and time to event analysis to evaluate early and late outcomes. We looked at the yearly trend in use of annular enlargement over the study period and see here that there's no significant change between 2008 and 2016. When we assess baseline characteristics and operative risks, we see patients undergoing annular enlargement were significantly younger and had lower rates of preoperative comorbidities. However, there was no significant difference in the predicted risk of mortality based on STS risk scores. However, when we compare patients undergoing annular enlargement to those who did not undergo annular enlargement but were at risk for moderate or severe patient prosthesis mismatch, we again see the patients were younger. However, the preoperative comorbidities were significantly worse in the patients with moderate and severe patient prosthesis mismatch, and the STS predicted risk of mortality was significantly higher. When we assess short-term outcomes, we see that operative mortality, major morbidity, and the composite major morbidity or mortality were significantly associated with annular enlargement in unadjusted models. This was again true after STS risk adjustment, with an odds ratio of 1.55 for operative mortality. However, there was no statistical association between annular enlargement and postoperative pacemaker placement in this cohort. Next, we assess non-fatal long-term outcomes, and we see here that hospitalization for stroke, hospitalization for heart failure, and aortic valve reoperation were not significantly associated with annular enlargement in unadjusted or risk-adjusted models. When we assess long-term survival using landmark analysis, we see over the first 3 years, annular enlargement was associated with significantly higher risk of mortality. However, after the first 3 years, this was associated with a significantly lower risk of mortality in unadjusted models. After risk adjustment with the STS risk score, we see again higher risk over the first 3 years with no association between annular enlargement and survival after 3 years. This figure demonstrates the survival curves and how they cross at approximately 3 years, with annular enlargement group, illustrated in blue. There are important limitations to this study, including the STS database does not capture the specific annular enlargement technique performed. The study was limited to patients over the age of 65 on Medicare in order to obtain long-term data on readmissions and survival. However, this may not be representative of outcomes in all patients undergoing annular enlargement. Finally, patient prosthesis mismatch calculations were based on valve size used and patient body surface area, which does not readily identify patients who were spared from moderate or severe patient prosthesis mismatch with an annular enlargement. In conclusion, we illustrate no change in national trends of annular enlargement through the rise of TAVR and valve-in-valve TAVR. We demonstrate an increased short-term morbidity and mortality in the Medicare population undergoing annular enlargement. And we established no association between annular enlargement and long-term reoperation, readmission for heart failure, or stroke, regardless of projected patient prosthesis mismatch. Finally, we highlight that survival curves cross after 3 years, suggesting a potential long-term benefit with annular enlargement in selected patients. So in closing, annular enlargement is still only done in the minority of patients over the age of 65 who are at risk for patient prosthesis mismatch. Increased early risk with no clear long-term benefit was seen in this Medicare population. However, annular enlargement may be considered in patients with predicted moderate to severe patient prosthesis mismatch in whom a long-term survival benefit may outweigh the early risk. Thank you, and I'd be happy to take any questions at this time.